Thank you, Victoria. We have time for a few questions. First, for any of the speakers, by the way. First to Dr. Hughes. THC is a potent vasodilator. It is known to cause hypotension. You have any concerns about its use with respect to optic nerve perfusion, since we know that lower perfusion pressure is a strong risk factor for glaucomatous damage?
That is correct. So there is no data showing that. That is a known complication, that THC does cause vasodilation, and in relation to intraocular pressure, you can get reduced perfusion pressure. It's hard to know what would have the strongest effect on the optic nerve, whether it's the neuroprotective effect of the excitatory pathway cascade, which is created by the excessive glutamate, versus the vascular consequences of the THC. So that is true. Consideration is there, but it's hard to know which of these would have the greatest effect on the optic nerve.
Okay. Thank you.
Thank you. Two-pronged question for Dr. Friedman. One about the applicability of the ZAP study to the U.S. Population. The other is if a clinician estimates the angle to be occludable, is it ethical to just watch it?
So I'll answer the second. I watch a lot of people with angles that are narrow. I'm not sure about the term occludable. I don't really know who is and isn't going to occlude. I think there is good evidence now from our research and also from lots of people out there. There have been massive studies of dilations of populations where nobody developed angle closure. In Germany, they evaluated a huge number of people for diabetic retinopathy, and there wasn't a single case. In terms of the ZAP study and its applicability here, obviously every population is different. Chinese have much higher rates than in European-derived and African-derived populations. We don't really have great data on Hispanic populations, but my guess is that the very low rates of events that we saw in China would be similar to what we would see here.
Next is a question for Dr. Goldberg. Could nerve fiber layer edema explain your findings of a thickened nerve fiber layer after the use of growth factors?
Absolutely, yeah. So we know that the nerve fiber layer is made up not just of the retinal ganglion cell axons, but also of what are called nerve fiber layer astrocytes, which are glial cells surrounding the axons, as well as vascular endothelial and parasite-associated cells in the arterioles, venules, and capillaries. All of those are actually known to respond to certain growth factors. Astrocytes in particular respond to ciliary neurotrophic factor. Positive or negative effects could be derived from effects indirectly on astrocytes or on vasculature in the case of different drugs. And that's really where the correlation with some metabolic or functional outcome is going to be critical in these studies.
Thank you.
One question for Dr. Huang. Can the use of latanoprostene, Bunod, and nitazoxanide predict MIGS efficacy?
Predict MIGS efficacy? I mean, I can say that that question hasn't been explored. I think the first question is like, will it even be additive to MIGS? In addition to, I guess, can it actually predict it? I don't know that we have anything that predicts MIGS efficacy. It's something that needs to be, evaluated.
This is a question for Dr. Searle. Janet, at some point, does more and more drops reduce the patient's ability to use any drops, except, of course, when they come to the office?
You're asking about compliance, and we all wonder if the patients take their medications for the 24 to 48 hours before arriving. And I think we can measure whether or not they do if we believe IOP causes progression based on the testing we use, the fields and the OCTs. So if you're getting great pressures in the office and things are progressing, that should be added to the red herring list I threw up. And again, every patient has a different tolerance to the number of medications, the type of medications, and which ones are going to be efficacious when used alone and in combination.
Yeah, thank you. That's a hard question to answer. One last question we have about shunts. So, Dr. Addis, do you notice any difference when you put you're recommending the shunt superiorly? Do you notice any difference between the temporal and nasal quadrants in terms of erosion?
I don't think that study has actually been done. I think they're easier to put in the temporal quadrant because it's just an easier surgery to do, but I don't think that question has actually been answered.